Next up, we have Noah Dinesh, a research coordinator at the Total Lipedema Care in Beverly Hills, Tucson, and Dubai, talking about advanced anesthesia for outpatient high BMI surgery.
Thank you. Thank you. Hi, everyone. My name is Noah Dinesh. I'm a research coordinator for Total Lipedema Care and a medical student at the USC Keck School of Medicine. I'm very excited today to be talking about a very important topic. There we go. I'm very excited to be talking about a very important topic, and that's high BMI outpatient surgery and the anesthesia involved. We heard a great talk on tumescent anesthesia, and we'll be talking now about general anesthesia. Nothing to disclose. And there's going to be two umbrellas. We're going to be talking about overall anesthesia, and the second part is the post-op recovery and the adjunct therapies that we have. At Total Lipedema Care, we like to call this part the protocol, the Schwartz rapid recuperation. So just to begin, just the traditional anesthesia that we have is gas anesthesia, inhalation anesthesia. This typically uses gaseous anesthesia, and one of the challenges with that is that it's fat soluble. So it remains in the adipose tissue for a few days after surgery, and that can lead to lingering fatigue and nausea. Dr. Schwartz likes to describe that as being hit by a Mack truck. That's how it feels. With total intravenous anesthesia, one of the benefits is that it's less fat soluble, so we get less of that lingering effect of the anesthesia. The anesthetics are delivered intravenously, and we have a lot more control. We're able to get an exact dosage, see how much is going into the body, whereas in gas, there's a little bit of unknown about how much is actually being absorbed by the body. So now I want to talk about the high BMI misnomer. A lot of times we think about obesity and high BMI as the same, or people tend to do that. I think in our audience here we're a little bit more aware about the difference. But high BMI and obesity are different, and when we're talking about anesthesia, that's very important. One of the big challenges with high BMI surgery and anesthesia is the airway. With more classical obesity, we see a lot of tissue around the neck area, and that can impede the airway and make it more challenging to maintain an airway during surgery. However, as we know, with lipedema patients, a lot of the density, a lot of the adipose tissue is concentrated in the lower extremities, and that removes a lot of the tissue that would have been around the neck area in high BMI patients. So we have three images here I think are really great at showing a patient with 46 BMI, a patient with 36 BMI, and a patient with 48 BMI. And as you can see, their neck area is average size, and most of the high BMI value is coming from their lower extremities. So this I just wanted to highlight is the fact that when we're doing a intubation, we face much less challenges in the airway in this factor. So the key here is that we're looking at, when we're considering a patient for high BMI surgery, we don't want to just look at one factor, high BMI or not. We want to take it in a broader sense, in a multifaceted sense, where we look at where their fat distribution is it impeding their airway, the potential for impeding their airway, in addition to other health complications they may have, and other experiences they've had with anesthesia. So we have to take these all together when we're considering anesthesia and not look so simply at just a yes or no. So to get back to TIVA, to go a little bit more in depth on the comparisons, with gas, some of the challenges that come along include being inhaled can lead to respiratory irritation, and with gas leakage, it can lead to some dangers to people that are in the operating room. The multimodal approach we use at Total Lipedema Care as part of the protocol, it's manually controlled infusion. It's pretty much opioid-free for the majority of the patients. And we use the stepwise analgesia that includes propofol, ketamine, and Precedex. And through this protocol, we've really been able to notice that we're able to do safe and effective anesthesia for these patients. So safety is a really fundamental part of the experience when we're looking at anesthesia. And there's a few different aspects, some adjunct aspects that we want to consider when we're looking at doing anesthesia for these patients. One of which is being an EEG SedLine monitor. This is a great monitor that in effect shows brain activity and can help us indicate where the patient is and whether they're in that window we want them to be throughout surgery. And studies show that this is a great tool to have alongside TIVA. Another aspect is with TIVA and with anesthesia in general. It can disrupt the temperature control that we have in our bodies, so it's important that we have other safety mechanisms mechanisms like a warming bed and a warming blanket to avoid the risk of hypothermia. Alongside that, there's also, in that same vein, we have warmed IV fluids, also reducing the risk of hypothermia. And when we're talking about intubation, we've been using a laryngoscope that has a camera so that we can get a good view when we're looking for the patients. So in the interest of time, we're just going to move to the final. We won't talk about the medications, but really the key we wanted to talk about the medications is that we're opioid-free. The majority of our patients, Eva, in the next talk, will be talking about the results we've been getting from our retrospective paper. And really, we've been seeing opioid being used a lot less. Patients only need to use it really, if not the day of surgery, just the day after, and not after that. And in a public health lens, it's so important that we're able to reduce the use of opioids for people who don't require it. With that, thank you all very much, and this is our information. We have Mark here. Mark does anesthesia with us at Total Lipedema Care. So if you have questions, this guy is a wealth of knowledge, so please talk to him, and I'd be happy to exchange any ideas as well. Thank you very much.
All right, thank you, future Dr. Dinesh. Yeah, just a quick question for you. For patients that also have some extra adiposity around their upper airway, which can happen, how do you manage that in your facility?
Yeah, that's a great question. So for each individual patient, like we mentioned in the early slides, we make sure we take a look at each patient's unique case. And as part of our research for anesthesia, we've been measuring a lot of different objectives for anesthesia. We've been measuring the neckline and the intubation attempts. We haven't noticed an increased intubation attempt with patients that are lipedema and high BMI versus those who are not. So we take each case by case, and we make sure that it's the safest for the patient. We consider all other health, past medical history when we're looking at the best approach for that patient. Thank you.
Thank you very much.
Thank you.